Hello, I'm Dr. Steve Kopetsky, preventive cardiologist at Mayo Clinic in Rochester, Minnesota. We have another segment of our interviews with the experts on preventive cardiology. Today, I'm very pleased and honored to introduce my colleague, Dr. Amir Lerman, who's a professor of medicine here. He's been very active in our research group, was head of research at Mayo Clinic in cardiovascular diseases until just recently. So welcome, Amir.
Thank you. Thank you for the invitation. I'm honored to participate.
Well, this is, I think, a very interesting segment today on the effects of social isolation and loneliness on the heart. Now, we've known for decades that that's played a role. I remember when I used to work in the CICU, a paper came out in the Annals of Internal Medicine, said you ask one question, basically, does anything or anybody care if you're alive? And if the answer from the patient was no, their risk of mortality from that heart attack went up, doubled.
Right.
So how did you start to think about this question?
So I was interested in the area of social interaction and isolation for quite some time, and several things happened. One of them, Mayo the cardiology, when they start doing an AI algorithm, one of the algorithms that came up was ECG age, which is not necessarily your chronological age. And I was curious, what's the mechanism of somebody presented with a 60-year-old, but the electrocardiogram said they're 65 or 70. Mm-hmm. And the second, at the same time, in the last several years, you guys in prevention started administrating questionnaire to all our outpatients, asking them specific question on isolation and social interaction. Mm-hmm. So my interest is that to find, you have a phenomenon of the algorithm. Algorithm is by definition AI, doesn't reflect mechanism. It's just association and link. But I was interested to see if there is any link between them, or what's the mechanism, why the electrocardiogram will say that this individual is older than his chronological age.
Interesting. So we had a recent segment with Dr. Francisco Lopez Jimenez about the ECG age as derived from the ECG. Yeah. So you used that and compared it to the questionnaire. How did you, what was your questionnaire?
So the questionnaire was is a 90 question that is administered to all our outpatients, and essentially ask questions that reflect social interaction. How many times do you talk to your friend? Do you participate in any religious synagogue, church, any other religious activity? Are you involved in any other social activity? Are you in touch with your family? Are you married? Are you in touch with your children? So it's all created like a score of that create a social interaction score. And then we took these individuals, we have about 90,000 of them, and we compared their delta ECG, or what the ECG showed, reflect their age, and compared to the questionnaire, and it came out that the individuals, two findings, individuals that have high score of social isolation, have higher delta ECG age. That means their biological and cardiovascular age is higher than chronological age stated. The second finding is that if your electrocardiogram age is higher and you also in the group of social isolation, your mortality is higher in follow-up of several years. So it's not entire mechanism, but association with social interaction and also associated with increased mortality.
Fascinating. What percentage of people do you find have social isolation, and how does that compare with age, gender, rural versus urban?
Great question. So there is some debate about the prevalence of social isolation and also accompanying loneliness, because there are two different terms. They usually overlap, but not necessarily overlap. In the group of age above 65, more than 30% in multiple studies are defined as socially isolated. Higher are lonely, reflect loneliness, but which is a more perceptive feeling. but in several studies, it ranged between 25 to 47%.
Right.
Above age of 65. Interestingly, the Z generation, the younger people between 18 and 22, even have higher rate of social isolation based on what we judge currently social isolation. Maybe they don't perceive it, but based on the questionnaire, because of the social media and all the interaction, they probably have not less social isolation than above 65.
Boy, that's telling us something about our current use of media, like digital media. And what about rural versus urban, or men, women?
So women are less socially isolated. Their score is usually lower than men in general. We didn't find much of a difference in rural and area that are not rural, and it does just reflect that in some of the rural area, families and groups are actually gathered together rather than in big cities. But essentially, not a lot of difference.
I see. So you said there are quite a few questions in the questionnaire. They're shorter ones now. Have you compared it using, the 4 or 5 question social isolation?
Yes, and we did, and it showed the same.
Showed the same. So we can do the short social network index or something like that with our patients. That's very helpful. And what do you think the mechanism of this is?
So again, fascinating. We have the phenomenon. We need to understand the mechanism. And until recently, there was not much interest in the mechanism. However, in the last year or so, there are several studies that came up that reflect mechanism. One of them is in the British the British Blood Bank, about 40,000 individuals. They found out that biomarkers that are reflecting inflammation are higher in individuals with social isolation. Not only that, in subgroup that they did a MRI, they found area in the brain that are connected to social interaction different in size between these two groups. So there is currently increasing evidence that there is also reflection in proteomic and related to social isolation. Another fascinating study came out recently in the last 7 months that was more reflecting the social bond retain oxytocin-mediated brain-liver axis to reduce atherosclerosis. So this was done in the animal models that where they have more social interaction, they have actually mediated through the liver reduction of diffuse atherosclerosis. So, and we know from other studies that the hypothalamus size also is different in individuals that are exposed to chronic stress or not. So recently, it's not only a phenomenon, it's also the reflective mechanism that associated can explain some of the cardiovascular disease. We actually find out in one of our studies that the delta age gap fits to the presence of endothelial dysfunction. So early disease of cardiovascular disease. Before you have any significant disease, you already see these differences in electrocardiogram age.
Yes, that's been seen in other areas too, that where the ECG actually picks it up sooner than we would have otherwise thought. That's fascinating. So it really incorporates everything. It's not just the cholesterol, the blood pressure, this loneliness. It's also what the body is seeing, what the heart is seeing. What did you have any opportunity to look at ways to help these patients or help patients with social isolation?
So I think the first step is recognition. And we in our practice are not yet prevalent to ask our patient what is their social interaction or social status. After they did the study, I started asking my patient. They were surprised, but I think it's important to document. If somebody is socially isolated or feel lonely, it's the same way that you ask him about cholesterol and hypertension and diabetes, because in this study several years ago, they impact of social isolation was higher than high cholesterol and smoking in this above 65. So first of all, recognition, not only recognition in our medical level, but also in higher level. For instance, in the UK, 5-6 years ago, they appointed a minister for loneliness. They recognize it's a huge issue, and they have a minister that currently it's also very prevalent in Japan. In Japan, for instance, because of the low birth rate in the distances, the government sending these elderly, lonely, and social isolated people robotic pets to interact socially. So I think the first phase is recognition. I'm not currently think we have enough evidence to treat in any medications, but I think creating a program to have these people less socially isolated. We know that even access to supermarket and access to food easily in some isolated place, it's important. We call food security is also associated with that. So I think recognition and start addressing. We need, of course, like in everything in medical field, we need a randomized study, but I think hopefully something will come up. I'm not opponent of treating them with medication at this point.
Now, getting back to something you mentioned earlier, which was the kind of the younger, the X, Y, Z generations. So we can't assume that digital media, a screen in front of you, takes care of social isolation, even though you're talking to people and interacting with people.
Correct, and we grade them on the social isolation based on the criteria that we created in our generation. It might be that for them, it's not considered social isolation. It's like when you and I grew up, a friend was a friend, not a Facebook or friend. So, I mean, it's a different definition. But we do see in this generation more loneliness and isolation. And, unfortunately, we see higher rate of suicide in this group in some countries in the US. So it does reflect on outcome, I believe.
Yes, and that generation you're speaking of is one of the most stressed generations in the history of the world.
Absolutely.
Very true. One last thing, the Rosetto effect.
Okay. That's one of the things that actually got my interest also several years ago to look at that. So the Rosetto effect, in 1960, there was a physician, I think his name is Dr. Schwartz, who came to one of the area in Pennsylvania and gave a talk about cardiovascular disease. And they told him, I think in 1961, they told him that there is a community in Pennsylvania that they have the lowest rate of cardiovascular mortality, half of the rest of the population. So he came back after 7 months with a group of students and started to look at what's the mechanism that. Apparently, this place called Rosetto in Pennsylvania, it's a small town that actually all of the people initially came to this were from the same name, Rosetto, from Italy. And they move as a community. When he looked at them, and I don't want to, I'm not encouraging any other of unhealthy behavior, but this population didn't keep their diet, were not exercising a lot, they were smoking. But the main thing that he found out different, and he compared it to small towns in Los Angeles, big town in Los Angeles, in Philadelphia, in Pennsylvania, really nice study. The only thing is that when they move into Rosetto, they move their community with them. So they move their family, they move their friends, they live the similar way that they live in Italy. And that the only thing that you can find. Unfortunately, when it becomes more modern and the effect decline, their mortality start being equal to other places in the United States.
So very similar to what we've seen with Loma Linda population, the other groups, the blue zones, et cetera. You need the social.
You need the social.
That's great. Oh, this is fascinating, Dr. Lerman. Thank you for educating us. The social isolation has a big role to play. Our younger generation is getting more of it, unfortunately, it sounds like, rather than less. The elderly are more likely, more than a third of the elderly have it, men more than women. If you have social isolation and you have a big increase in a higher increase in your ECG age, your biologic age, and those two combined lead to increased mortality. after a few years. This is a fascinating area, an area we certainly need to pay more attention to in our preventive cardiology practice, and need to start incorporating it, like you say. Just ask a patient in a very non-judgmental way, how are you doing with your social interactions and such?
How many times you go out, how many times you talk on the phone, all these little things.
Yeah, and it slips away from us very easily as we get busy. Well, this is a fascinating subject. And it's great to be able to get to speak to you about this. Any last words for us?
No, I first of all, I appreciate the opportunity to present it. I think it's important to start having people, the medical and non-medical community, be aware of this phenomenon.
And you've done a great job alerting us to it. Thank you very much, Dr. Lerman. We hope to speak again soon.
Great, I appreciate it. Thanks.
At Mayo Clinic, continuous learning fuels world-class care. I am Dr. Francisco Lopez Jimenez, Chair of the Division of Preventive Cardiology. If today's episode gave you a fresh insight, imagine what a full course can do for your patients. Please check out the link cveducation.mayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses created and taught by the very voices you trust here. Join thousands of clinicians who have already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.